So, hi everybody. My name is Arnon Nagler. I'm from Shiva Tel Aviv, Israel. And I guess in continuation for the IA meeting, the first big, I guess, or second big in-person meeting after 2 years and a half of COVID, I was asked to discuss how to select the best donor for allogeneic transplantation and also about GvHD. So I guess this is related to the talks that we had, the studies that we presented at IHA. We have shown that in patients that are transplanted in CR, if the CR was achieved after 2 induction therapies, lines of therapies, and not one, the results of the transplant is worse. We have shown it previously for haploidentical transplant in a paper published in BMT. It was shown for a sibling transplant and unrelated transplantation and autologous transplant. By the way, in cord blood transplantation, this is not the case, so we were not able to show that the result of the cord blood transplant in patients that needed 2 induction therapy to achieve CR was worse than those that need 1 induction, speaking for the maybe stronger graft versus leukemia effect in cord blood transplantation. So now we ask what is the best donor for those patients that needed 2 induction therapies to achieve CR. And we compared a sibling donor, which is of course the preferred donor if you have it, but we compared alternative donors. So unrelated, 10 out of 10, mismatched unrelated, 9 out of 10, and haploidentical transplant, and we're able to show that at the end of the day, the leukemia-free survival, the overall survival, and the GvHD-free, relapse-free survival is similar between haploidentical transplant, matched unrelated transplantation, mismatched unrelated transplantation to sibling transplant in patients that don't have a matched sibling donor and they achieved the CR pre-transplant after 2 induction therapies. There was a bit more or significantly more acute GvHD, grade 2 to 4, in the mismatched and matched unrelated and haploidentical transplant. And for mismatched unrelated transplants, there were a bit more chronic GvHD and lower significantly GvHD-free, relapse-free survival. So this brings us to the question of how to best select a donor. In all the studies that we have done from the Acute Leukemia Working Party, this is a registry-based study with the limitation, but always matched sibling donor and the matched unrelated, 10 out of 10, was the best donor. And only then was the haploidentical transplant, and 9 out of 10. If you don't have matched sibling or unrelated donor, or you don't have time to look for, then haploidentical transplant is the same like a mismatch unrelated, and at least in our center and in many other centers in Europe, we are going now for a non-T-depleted haploidentical transplant in those cases with post-transplant cyclophosphamide. So post-transplant cyclophosphamide have shown to change the biology of transplantation and reduce the chronic GvHD and transplant-related mortality. And in another set of data, we have shown that over the last few years or so, with using of post-transplant cyclos, the haploidentical 3-year overall survival of haploidentical transplant almost double, and the transplant-related mortality was reduced by half. There are some data that even the graft versus leukemia effect, like incidence for Hodgkin lymphoma, is better for haploidentical transplant. We, in our studies, failed to show stronger GVL effect or lower relapse rate, I would say, in the haploidentical transplant, and we believe that the GVL effect is stronger, but there is also the loss of haplotype, which increased relapse rate in haploidentical transplant, and therefore, not all the studies show reduced relapse rate in haploidentical transplant, but yes, most of the studies show reduced transplant-related mortality and chronic GvHD. So for the question of prevention of GvHD, of infection during GvHD, so we have the revolutionized anti-CMV prophylaxis with letermovir, and which really reduce the CMV activation and CMV disease. And as for GvHD, there are recent publications that if you give prolonged administration of the letermovir more than the initial studies, then the activation in CMV and CMV disease is lower. And the other issue is the fungal infection with posaconazole versus fluconazole in the New England Journal of Paper. Still argument because of the cost of fluconazole and the overall fungal infection rate in GvHD patients were not reduced, but the aspergillosis infection and the death from fungal infection was reduced with fluconazole. Now, in the EA, there was several studies about prevention or treatment of GvHD. One study was from China with cord blood mesenchymal cells that were able to reduce GvHD after haploidentical transplant. There was a study from Switzerland about blocking the mobilization of the T cells. And there was some mice work from Germany with defensin, and another study from China in mice and samples from patients with combination of glucosteroid and blocking glycosylases. So there was some advantage in the GvHD, and I would say that one of the most important studies was, again, when we talk about selection of donors, was the study, multi-center French study directed by Professor Didier Blaise from Marseille, that this is one of the first two-arm studies of haploidentical transplant and unrelated transplant in about 110 patients. What the study shows that there was some delay, about 80 days between the randomization and the transplantation, and about 20 to 30% of the patient could not get the transplant. But in intention of treat analysis, there was no difference in leukemia-free survival, overall survival, transplant-related mortality, and relapse between haploidentical transplant and unrelated transplant, and this is including in elderly patients. And as for the selection of donor for haplo, we have shown in a recent paper from the acute leukemia, we could not find a correlation with kinship, as the KIR mismatch in our hand is not preventing relapse rate. And maybe most important, that in haploidentical transplant, in contrast to sibling transplantation and unrelated transplantation, there is no correlation between the GvHD and GVL effect. So patients with acute or chronic GvHD did not have the higher relapse rate than patients without GvHD, speaking for the dissociation of GVL and GvHD in haploidentical transplant with post-transplant cyclophosphamide.